Welcome back, everybody, to the Catalyst Pharmacy Podcast. Today we had someone who really doesn't need an introduction, but I have one anyway. It's Benjamin Jolley, Senior Fellow at the American Economic Liberties Project, lead luminary for CPSN Utah. Also, him and Joe Williams are founders in Apex Consulting. They help a ton of pharmacies across the country just operationalize different things in their pharmacies. Also, if you're not subscribed to it, it's free to. He has a Substack of, I think it's named Ramblings of a Pharmacist, but Ben Jolley has a Substack. So go look him up. Go follow that. We go over a lot of the just PBM reform he's doing. He talks about his experience speaking to 20,000 different people or plus while he was there in Salt Lake. Really cool experience, cool story as well. And then just like PBM reform, what's on the horizon, like what's in the current budget bill. So if this ages and you listen to this like 3 months from now, sorry, that's what we had at the time. And a little bit of what's happening just with his pharmacy and what he's helping pharmacists with. So Brandon will take you there now. Can you tell me what it was like, or tell everyone what it was like speaking to that many people? I've only spoken to maybe 400 before, and I'm not good at it at all, to be really honest. I'm more of a one-on-one, 5-on-1 kind of guy. Like it's a different story when you're speaking to, I don't know how many thousands of folks you spoke to about PBM reform.
Yeah, so there were apparently 20,000 people there, 15,000 inside the building, 5,000 outside.
Wow.
That was nuts. It was definitely a different engagement speaking experience than I've ever had before.
Yeah.
They told me to have comments prepared for 3 minutes. Took me 7 minutes to deliver those remarks that I had practiced like 30 times. And I was like, yeah, got it down to 2 minutes, 59 seconds. We're golden.
Nice. We're good.
But I didn't account for the fact that when you speak to that many people and they boo and they cheer, you have to account for that time.
You have to leave room.
Remarks. Yeah.
You have to leave room for that, is what you mean? Okay.
Yeah, apparently it takes like more than twice as long to say the same remarks. Anyway, it was exhilarating. It was a friendly crowd, right? These were folks that were there to be inspired, and it wasn't a like angry mob that wanted to get me.
Right.
But it was a really cool experience. I mean, it feels pretty good to say, I work for the oldest pharmacy in Salt Lake City, Jolley's. Yeah, Jolley's, woo!
Right.
And then say,
no, that's good.
And there's this other company, CVS Caremark, boo, CVS, boo! And then this other person's insurance was through OptumRx, boo, Optum. OptumRx, which is the pharmacy division of United Healthcare.
Yeah.
People were really mad when I said United Healthcare, which is like, that was actually kind of frightening at that point.
Yeah.
Like, exhilarating to speak in front of so many people, but honestly frightening when I hit like a nerve. Anyway, that was definitely one of the coolest experiences of my life. Like, I've spoken in front of, a couple hundred people.
Yeah.
Maybe 1,000 at a time, but like
that's
also
a stadium almost, right? Like
it was the UView basketball stadium, Huntsman.
Oh,
Center.
okay. That's what it was.
Yeah.
All right.
Yeah. So yeah, it was a stadium. And that's anyway, exhilarating. And like having my neighbor introduce me and then everyone like cheering as I go on stage really calmed my nerves and made me just excited to be there rather than like freaked out.
Yeah. Well, that's good. Like you said your neighbor introduced, like your actual neighbor? Like
he lives 4 doors.
Neighbor. Oh, okay. Right on. Well, that helps too, right? A familiar face and all of that. Yeah. I was just trying to think through. I was like, man, one, you did a great job. So, I watched it. A lot of us watched it. But it did seem it was I'll just say an active crowd. That's for sure. And
when I said United Healthcare, it was definitely an active crowd. People were like flipping double birds at me.
Oh my God.
And I was and yelling slogans. And I was like, wow, okay.
All right.
This is a crowd. Which like I want reform to happen.
Sure.
I want it to happen peacefully.
Yes.
Right. Because we have a political process for a reason. Because like if you take away people's ability to get justice and reform through the political process, the alternatives are not attractive.
Never are. Yeah.
Right. And so anyway, I was really pleased though, like after that, people right afterwards said like they were inspired by my speech. They were like, wow, that's really cool. The pharmacy has seen a decent number of people just transfer their profiles to us because they saw my speech. So that was cool.
What do you mean transfer their profiles? What do you mean?
I mean, people brought their business to Jolley's.
Got it. That was
yeah.
All right.
I was like, I wasn't sure what to expect in terms of like, what is the impact on the business of speaking out at a very left leaning.
Yeah, I know, right? Yeah.
And when I was thinking about it, I was like, I think I was right in my calculus that people who care would like appreciate it, and people who aren't like on that side of the aisle just wouldn't notice and wouldn't care.
Yeah.
And I think that's been the correct assessment of how this went.
Yeah, and I would think if they just listened to it too, if you actually would just take the time to listen to it, there's nothing partisan about what you were saying, in my opinion.
No, I mean, like just for clarity of how not partisan this is, I was at a Bernie Sanders rally giving this speech.
Yeah.
Which is like as far left as you can go.
Yeah.
3 days later, Sarah Huckabee Sanders signed a bill into law doing something very similar to what I was asking for.
Yeah.
Sarah Huckabee Sanders, if you recall, was the press secretary for Donald Trump 6 years ago.
Yep.
So like this is not a right-left issue.
It's not. Yeah.
It's a corporate versus the people issue, right?
Yeah. No, it was good. It was good. So anyway, I don't want to like stay on it too much, but man, it was good. It was cool to watch. It's just like I think we have Darren on later, and as far as like you got to speak to all of those folks, he got to go to the White House, I think once, maybe more than once, I don't know, but like it's good to see just pharmacists in general being really active about the situation that exists, and it looks like at least at a state level, there's seems like there's wins happening all over the place to a degree. Obviously, none of it's as much as you'd always like, but I guess speak to what you're seeing broadly and kind of the legislative efforts, if you can, if you feel comfortable talking about any of that.
Yeah, so like I've seen like a lot of bills passed lately that have been pro-pharmacy, and I think they mostly fall into 3 or 4 buckets. Bucket 1 is just like minimum payment, and just rate regulation. Montana passed a bill this year that says thou shalt pay pharmacies NADAC plus $15. Let's see, Alabama passed a similar bill that says you'll pay at least the Medicaid fee-for-service rate, which is similarly NADAC plus a meaningful dispense fee. That kind of legislation has been fairly popular, fairly successful across the country. I mean, there's a bill sitting on the governor's desk in Colorado that says you shall pay NADAC plus a reasonable dispense fee. It doesn't actually spell out dollars and cents.
Script it. I just saw one from Iowa too. Literally today I saw it. I don't know when it was actually passed, but I don't know if it's been signed yet. But basically if you're a smaller, what they deem a smaller pharmacy, and I think smaller is 20, like less than 20 stores and not publicly traded or something like that. A $10 or $10.68 or something like that dispense fee. I was like,
so like that's a meaningful reform because in my mind, like there's basically two problems. One is the middlemen are just stealing all of the money, and the other is that there's no floor to reimbursement. I mean, in my speech, I gave the example of getting paid 35 cents for a seizure medicine,
right.
Which is like, what can you buy with 35 cents? Right? Like
you can't even pay for the time it took the staff to fill it with that, right? Like
not even close. I mean, it costs us
even
like
a little bit.
$10 of staff time. But like, I mean, we couldn't even get the pills for that price. Like the bottle itself, is
the
that
label,
price. The e-script fee is like you add up the e-script fee, the transmission fee to the PBM, and like you're already there, right?
Yep.
So it's just like it's insultingly low reimbursement, but like I think that comes from a place of PBMs doing what I describe as a cream skimming scam, where like you push down the reimbursement on the majority of drugs that are commonly prescribed, dispensed everywhere, and then you use that money that you've extracted from those drugs and you put it into a bucket of very high reimbursing drugs, and then you make sure that all of those drugs go to your own vertically integrated pharmacies. Right.
Okay.
And so that way you can say I brought down drug prices for you, employer, while taking gigantic profits for yourself. Anyway, I think that the incentive to play that game goes away if you just say no, you can't pay pharmacies that way, or
right.
B,
from a regulations / legislative perspective, you're not allowed to do it.
Right.
Yep.
Or B, you go the route that Governor Sanders signed into law, which is you just say you can't be a pharmacy and a PBM. The end. Which to me is like a very common sense regulation to say, like, look, if you want to be a pharmacy benefit manager and like be in charge of payments to pharmacies, you shouldn't be allowed to also be a pharmacy at the same time. Like, choose your lane. Right? Are you trying to make money by selling more drugs, or are you trying to make money by helping people reduce the cost of drugs? Because those are at odds with each other. And if you are in both sides, your decisions are going to be corrupt. Right? And anyway, so that's like, I think the goal that I want to get to.
Okay.
And that's the second bucket. There are 5 states right now, in addition to Arkansas, that are debating similar legislation to
really?
House Bill
I didn't know that.
1150.
Okay.
Yeah. New York has Assembly Bill 6587. New Mexico has a bill. I think Iowa. And I'm not sure.
Oh, okay.
Anyway, there are several bills. I think a bill file was opened, but the legislation isn't drafted yet in Utah, where I am. So, like, there's movement on this concept of you shouldn't be able to be a PBM and a pharmacy simultaneously, because it just doesn't, like, no one, when they think about it for 5 minutes, says, you know what would be a great idea? We should pay people to reduce the cost of drugs and also to raise the cost of drugs. That sounds like a great idea, right? That's the second bucket that I see of reform. The third bucket is like general, like, PBM licensure. Like that's a reform bucket as well. And I've seen bills for that kind of activity all over. And then the fourth is Medicaid managed care reform. Specifically, like Ohio, a couple of years ago, said, hey, managed care organizations, we're just going to have one PBM for everybody across all of Medicaid.
Right.
They took that approach. New York took the approach of saying, hey, managed care, we're just going to do all the pharmacy stuff ourselves. You can deal with, we'll still contract out for you for all of the medical and hospital stuff, but drugs, it's a simple thing. It's pills and bottles. We'll take on the risk there. And so New York took that back from, and so a lot of states have taken the approach of either saying we're going to have one PBM or we're just going to take on all of the pharmacy risk onto the state directly. And this is like phenomenally cost saving for states, but also it's meaningfully useful to pharmacies as well, because when you level out reimbursement as fee-for-service or single PBM legislation usually does, pharmacies don't have like any of the jackpot or like slot pulling behavior where you make money on 777 drugs and you lose money on everything else, which is the standard way that we make money in pharmacy today, unfortunately. But when you shift everyone over to just, you're going to pay on the same basis as Medicaid fee-for-service, then pharmacies make money by filling just more prescriptions, full stop, rather than,
Sure.
let me see which scam I can run today.
Yeah. The incentives are super weird in that way, right? Like to not want to dispense, or maybe not want to, but like being punished for providing good care, and then having financial incentives that drive you to potentially do other things.
Right. I mean, the financial incentives right now are like across all of PBM land that's not just like fee-for-service Medicaid is pretty much find a scam, like find some drug that you can switch people to that the PBM has inexplicably set a very high MAC price on relative to your cost of goods, and then just push that one drug really hard until they figure it out, and then do it again with something else. Which is like, I mean, I get it, that's fine, whatever, but like, I don't want to be paid for pushing weird drugs. Like, my favorite example of this is Zegerid.
Okay.
Just omeprazole with a gram of bicarbonate in it. Throw some baking powder in, and you suddenly get paid dramatically more. Like, in what world is that a good idea? Like, is that the way that we want to pay pharmacies?
Right.
I just want to be paid for rendering services, and like, I would like to live in a world where I'm relatively neutral as to the financial aspects of the drug, or really I just want the cost to go down, right?
Right.
Because the current status quo is like, my incentives are really wonky and weird, and only make sense in a world where you're running cream skimming scams.
And super dynamic, right? Like they're changing all the time.
Yeah. And it's just frustrating. I don't see it as a and like the other thing about the like status quo is that there's a saying, I think it's called Bentham's law. Bad money drives out good. It's in reference to like counterfeiting, and counterfeit money specifically, but like in the context of the way the current reimbursement system works, the response that PBMs have to someone going and exploiting some problem is they'll shut it down and then cut down the reimbursements on everything else even further. So that means that you're now making all of the pharmacies that would just be trying to dispense prescriptions to make money, you basically force them to become the entities that like you're worried about as potential sources of large losses to your plan. Or you drive them out of business, and then they get bought by the other pharmacies.
Sure.
Anyway, but yeah, I'm waxing kind of philosophical here. Uh,
Oh, you're good. That's what everybody's here for.
yeah. Um, so I will say one other thing I've been thinking about the last like week or two is Rite Aid's going bankrupt,
Yeah.
right? Um, there is a bankruptcy hearing on June 6th at 11:30 in the morning in New Jersey. I've been thinking it'd be really cool to have like a bunch of rallies all over the country at Rite Aid locations or former Rite Aid locations. Like there's a Dollar General here in Utah that used to be a Rite Aid, and like Dollar General.
Yeah. Are they out of Utah now?
Rite
Or
Aid,
they still
yeah,
got a little bit?
yeah.
Yeah.
Rite Aid
Okay. They're
sold
out.
all of their files when
That's
they
right.
tried to merge with Walgreens. All of the Rite Aids
Oh,
in
got it.
Utah got closed at that point.
That was part of it. Got it.
But like there are shells of Rite Aids all over the country. Um,
Hmm.
anyway, I thought like during the bankruptcy hearing on June 6th, it would be cool to have people just at Rite Aids all over the country saying, "Hey, CVS is buying 60% of the pharmacies
Yeah.
that's left of CVS of the files, I should say, for like pennies on the dollar. Um, like it ain't right that PBMs own pharmacies, so we should like have a mass protest at Rite Aids all over the country saying, "Hey, PBMs shouldn't own pharmacies," and like try and get local media and local blah, blah, blah,
Like
elected
a
officials
pop
there
up.
to like.
Yeah. Yeah.
Anyway, that's something I've been thinking about. Is like, hey, we should do something like that. June 6th, which is of course the first day of Catalyst. So I'm
It
probably going to try
is.
and find something in Texas, just outside, in the DFW area. Try and find somewhere to go, gather some people and get some local media. But we'll see.
Got it. All right. Let me know if I can help with that. Actually, I look at that and I go, I think it could sound like a press grab or whatever, but like I think it's truly something you're trying to benefit your entire industry with, of like using that as an example of just what's going on. Like it really is. Like it's the picture perfect example of, and a little bit of probably like consumer shift too. That's like maybe the huge store format isn't what consumers are leaning into too. So it's probably both, but to me, it's more of the reimbursement picture than it is probably the consumer shift as much. But
Yeah, I
maybe I'm
mean,
wrong. I
I
don't know
mean, there's
everything
there's a
about that.
lot of reasons. I don't think it's just that PBMs killed Rite Aid because, like, if you look at like reimbursement numbers um on Medicare.gov, for example, Rite
Sure.
Aid gets paid way more than me
Yeah.
for drugs. So it's
Right.
not just that PBMs murdered them, but it's like it's also the opioid lawsuit, and it's also um the shift in consumer preferences, and it's also just like and also. But like
Yeah. Yeah. Yep.
I think that the PBM um reimbursement angle is not nothing either.
Oh
Um
yeah. It's definitely in the top tier of what happened. Right. Like if it's that's two other things joining it, okay. But I would equal weight them if we're gonna be generous.
right, exactly. So like it's something where and like those stores are going to be out of business by the end of the year anyways, so I
Yeah.
figure it's a opportunity to um not let a crisis go to waste, as they say. Uh so um
Honestly, it's all for like just bettering the industry. So I don't think anybody would see it otherwise. I was going to get into a little bit of. I want you to tell me again the. I'll just say the advocacy group you're a part of. I called it something that totally wasn't last time we talked.
the American Economic Liberties Project.
There we go. There we go. I always like, I think I default to acronyms all the time because of pharmacy in general defaults, I feel like, to acronyms all the time. So tell me about your work there. Like what's changed or what have you done or what an update on that?
Yeah, I mean, so that was how that speech happened. Um
Okay.
was through connections there. But I don't know. I've done some work around various regulatory initiatives. With like the FTC has this docket where they want suggestions of what can we deregulate to try and get more competition. So been working on a like, hey, here's some ideas of things you could deregulate. Like if you delete this section of this code, then theoretically we should have more competition. So that's an interesting way to get at the goal, but like that's where the current administration is.
I haven't thought about that angle at all.
Yeah,
honestly.
Yeah, I mean the current administration is all like, let's just like go cut 20 pages of regulations for every one page we add, and all of this like Doge style stuff. And so, they're the party in power, and so we try to speak their language.
Yeah.
So that's been interesting. I don't know. We launched a campaign called Break Up Big Medicine. Breakupbigmedicine.com. I said that in my speech as well, but like that's us as well. At AELP, if you want to use the acronym initialism, whatever. AELP. But the concept being like bigger than just the PBM issue that I've described, where you shouldn't be able to be a PBM at a pharmacy. I think the broader concept that Break Up Big Medicine embodies is like, you shouldn't be able to be a physician office or a hospital and be an insurer at the same time. Because again, same kinds of conflicts of interest. Like, I want those people to be at opposite sides of the bargaining table from each other, not the same side of the bargaining table. And so the concept here is like, we should say, if you are, the way I put it in my head is, if you're in charge of managing other people's money, you should be on one side of the wall. If your job is providing services to people, getting paid out of that other people's money, you're on the other side of this wall, and you can't be in both buckets at the same time. The like archetype of this business model where you're on both sides is United Healthcare, right? They have OptumRx specialty pharmacy, OptumRx PBM. They have General Healthcare Pharmacy. They have United Healthcare Insurer, an Optum physician group that employs like 100,000 physicians or something to that effect. And like, it's not just United Healthcare, right? Anthem has Carelon, that's their PBM and also their physician group. Humana does the same kind of thing. CVS Health has CVS Pharmacy. Caremark has Signify and Aetna. So like, this is like how the insurance company conglomerates have organized themselves, but
sorted themselves. Yep.
But it's like, we don't think that should be an allowed business model. It should just be illegal. And so we've launched this campaign, and we're trying to get folks like excited about it, get folks to introduce legislation around this. So we'll see what happens there, but that's been an interesting, a really interesting thing from my perspective to just like be pushing forward on this. A friend of mine actually texted me after my speech and said, I think you're now the most watched person talking about the need for PBM reform ever.
That might be true between you and Anthony and Doug, and that's a what's good is the breadth of people doing it. It's great. Like, sure, some folks probably get more plays than others, right? But like, even at the state level, there's like small armies of people going, this just can't work like this. It's so actually good to see, and you're starting to see a little bit of success, but we'll see if we can keep the momentum going. That's for sure.
Yeah, fingers crossed there. Yeah. I don't know.
Speaking of that, I was reading through the bill as it states the budget. I guess it's really not a bill. The the big beautiful budget bill. I don't know how. I don't know the
I
names
think
actually.
the title of it is actually the One Big Beautiful Bill Act.
One. Yeah. Okay.
I think that's actually the title, which is hilarious to me.
Yeah. So I was reading through it and kind of what they're doing. But I don't know. Have you had to spend much time reviewing it yet, or
some?
I feel like it's changed every week too. At the same time,
right? That's the like. One of the things that's like frustrating to me about working in this environment is that like a lot of things are move slow and then move extremely fast, and then it's over.
Yeah.
And so like when those extremely fast moments pop up, you have to be like on your toes, ready to go, putting out fires right then, which is really tough to do. I mean, a few weeks ago, there was an amendment put into one of the bills that I think became part of the One Big Beautiful Bill Act, that would have eliminated the Federal Trade Commission. In effect, it wouldn't have actually done so. It would have just taken all of the resources at the Federal Trade Commission and said, "Here, Department of Justice, have these." But it wouldn't have given any of the like authority that the Federal Trade Commission has to the DOJ. So it basically just would have murdered the Federal Trade Commission with no authority transferred.
It would have
with it.
It would have hamstrung them or neutered them,
Yeah.
basically, in that regard. Yeah.
And so that was a big deal. Thankfully, it died at that point, but we'll see if that amendment attempts to get back into law again. We'll see. But like for pharmacy related stuff in this One Big Beautiful Bill, a lot of the PBM reform that was introduced in the December reconciliation package is in there now. Yep. Some of which is good, some of which is some of which might be actually a net negative, but I don't know. It's a, like, for example, there's a reform to Medicaid managed care that says you're just going to pay on the same basis as fee-for-service Medicaid, but also NADAC reporting will be mandatory.
Oh.
Which is a big change and almost certainly will dramatically
that will be a net negative.
NADAC.
Yeah, unless they segment it. Now that would be great if they segmented the NADAC. But
that may be where we need to go. But like,
honestly,
as it stands, I mean, as it stands, that mandatory NADAC reporting, I think this is a good thing from like a public policy standpoint. We'll know what drugs cost across the country, but for small business pharmacies who, from everything I can tell, pay dramatically more for drugs than their chain counterparts, that's a bad thing, right?
Yeah.
If you're getting paid based on the average cost, and the average cost includes people who pay 1/10 as much as you for some drugs, you're now getting paid 10% what the drugs cost.
Yeah, especially if its weighting is like representative of the market in general. Like if it's 50% of the weight, that's a net negative for sure. Unless they go segmentation based in some way, which
it's
hard to
do.
And
maybe that's where it goes. I don't know, but like as it currently stands,
it's not the way it's written.
I mean, the NADAC methodology gives every pharmacy one vote per NDC. Basically, it uses the last price that you paid for any given NDC as what your contribution to the average is. That means that one vote per store, there's like 60,000 pharmacies in the country, 20,000 of them are independents. So that means your weighting is 66% chain, 33% independent. Under a mandatory reporting framework, that means that we're going to need to see either serious reform in terms of how drugs are priced to pharmacies,
Mm.
Because like right now, the big wholesalers just like say, this is the price. You'll get a big rebate on it, hopefully, if you comply with our stuff. But those prices can be very, very different. And so, I don't know. And the behavior that we see, to me, is maybe questionably legal under a 1930 law called the Robinson-Patman Act that says you can't charge like higher prices to disfavored customers than you do to favored customers for the same exact product unless there's like a legitimate efficiency. Like if I buy a bottle and CVS buys a case, you can charge a lower price for a case or for a truckload
case.
of the
Yeah.
thing. You can't charge a different price because CVS buys more drugs, period. Right? It has to be tied to like the actual way in which the efficiencies are gained. And I have to have access to that same ability to buy at, like, if I were to buy a case, I get the same price, right?
Mm-hmm.
But there's strong evidence that that is not how drugs are priced by wholesalers at all. We talk about multiple maximum allowable costs by PBMs where they set different prices for me and different prices for their own pharmacies. But like the wholesalers do the same thing. There are as many catalogs as there are pharmacies, so far as I can tell. So I think that'll be a much more salient issue should this bill actually be signed into law, which every indication I've seen says probably yes.
Probably stays, you think?
I think
I'm not asking you to
does.
predict the future, honestly.
Well, I mean,
it could not, but
the mandatory NADAC thing, it's like projected to save the government like billions, like $20 billion over the next 10 years or something, which that means that it's coming out of the pockets of pharmacies.
Yeah.
So there's like, I like this from a public policy standpoint. I think it's good to have a sense of what the prices are. I think that without some degree of like, hey, you can't be pricing drugs the way you have, where you're charging favored prices to larger companies and disfavored prices to smaller companies, that'll have to change. Otherwise, we'll see just general harm from this. But like the government should pay based on actual real prices, and we should have public pricing that says this is what drugs actually cost. I think that is a good thing. But unfortunately, as it stands, more transparency in drug prices means cuts in prices because
if you don't change the methodology, right? Yeah, if you're not updating the methodology at which people get paid, then yeah, and everybody's
right.
How about the spread pricing piece? That's in there.
Spread pricing, like again, same kind of thing where you have to charge, like Medicaid managed care has to charge Medicaid the same price as they pay pharmacies, which is again like common sense type of stuff. PBMs, from my perspective, shouldn't make money from spread, especially in the case of like Medicaid, because spread exists in that market to just screw with government reporting, which is like spread pricing is great if you are a managed care Medicaid company, because it means that you don't have to pay your PBM out of your administrative budget. You can hide your PBM compensation in the claims, because from what you report to the state, every penny that you pay to the PBM in spread looks like money paid for claims. It's not.
Yep. It's just that entity's profit margin is up. Yep.
Which means that as a Medicaid managed care company, you love this. As a Medicaid director, fee-for-service director, you hate it, right? As a taxpayer, it's a total grift, because now all all of the payments to Medicaid managed care are based on this concept that they're going to keep like 5 or 10% for administrative cost, and everything else is actually going to go out to providers. If you hide that administrative cost inside of the claims by doing spread pricing, you're overpaying the managed care company, right? For the services that they're delivering. And so banning spread pricing, especially in Medicaid managed care, is a great idea. In the commercial market, like, I think that, I don't know if you've seen this, but a lot of employers have started to be sued for breaching their fiduciary duty under ERISA to make sure that plan assets under a
I have seen
health
this.
plan.
Yes.
I think that honestly,
I have seen that. Yep.
If your PBM is spread pricing you are probably not exerting enough fiduciary control over your PBM. And so, like, all of the PBM lobby will say, well, it creates more optionality for employers. But, like, I don't think any employer other than CVS, Caremark, OptumRx, and Express Scripts wants to have the option to pay their PBM in a way that they don't understand. Right? Because that's what spread pricing is. It's an option. Yeah. It's an option to pay your PBM in a way that
as
you don't
opaque
understand.
As possible. Yeah. Mm-hmm. Yeah.
And so, like, I think that removing that is a good thing. Anyway, I think that PBMs should be paid on a transparent basis of like PBMs do provide services, right, that are meaningfully necessary in the context of a third-party payment system. You need to have someone who has a computer system that can process claims, right? Pioneer doesn't exist without it doesn't exist in its current format, right?
Yeah,
without
the
there being
form. That's
someone
fair.
on the other side accepting the claims that we're transmitting.
That's fair.
That needs to exist. Someone needs to make sure that the pharmacies are actually giving people the drugs they say they're giving. If you're having third-party payment, because there's just tons of opportunity for fraudulent payment. Someone has to credential pharmacies, make sure they actually are real places with real staff, with real inventory. Because, like, unfortunately, there are fronts for the mafia that exist. Someone has to make sure that money actually flows, right? And I have enough annoyance just getting contracted with each of the PBMs that we do business with. I cannot imagine how frustrating it would be if I had to get a contract with every single employer in the country to get paid for drugs.
For every patient that walked in to go tick off their employer. Right.
Like, think about how many group numbers you see, and like, I need to go sign a contract as Jolley's Pharmacy with every single one of those employers. Like, no one wants that system. Contracting is annoying enough as it is. Like, someone has to make sure the money actually flows. Like, so when I submit a claim, the money flows from the employer's bank account to the PBM to me, or from the employer to me. However they want to set that up doesn't really matter to me, so long as I actually do get paid. And that's a meaningful service, right? Making sure monies flow, making sure that claims get paid timely is important. And like, setting a formulary is going to be a choice that most every health plan is going to have. Every country that has like a nationalized health system has a formulary. That formula usually happens to be the only drugs for sale in the country. If you can buy it in the country, that's it. It's on the formulary.
All the things. Yeah.
But like, formulary setting is a key component of providing third-party payment for drugs. And so, like, all of these are meaningfully useful services. The problem that I see is not the existence of someone who provides these services. It's that the way in which we've chosen to pay for these services is corrupt.
Yeah.
We pay people through spread pricing. We pay people through their ownership of a pharmacy that gets overpaid relative to competitors. Those are not fair, balanced, aligned payment systems. And so I don't have any presumption that we're going to live in a world where pharmacies can just bill and get paid usual and customary on every single drug all the time.
Right. Yeah.
But I want the person on the other side of the table to be an honest broker. So, which
no, that's fair.
Anyway, yeah.
There's also, and I don't know if your thoughts on that. There's also, it looked like some limitations around qualifications for Medicaid. I thought it looked like that when I was reading it. I didn't know if you had thoughts on that. Yeah, for patients enrolling, it looked like it's going to be a little harder to get it if you need it. And then potentially what that probably does, I was thinking downstream effects from that is potentially your LTC world and your LTC combo world where some of those benefits get paid are in the Medicaid channel. So I was just like, oof, that's the one thing. Like, you're right. There's some positives in it. It just, I don't know. I was looking at that going, it's just another, I don't know if you'd call it a net negative from a policy perspective, but at least from a pharmacy serviceable market perspective, probably. Yeah.
Right. It will convert so the biggest thing I've seen is Medicaid work requirements, which I think is a misguided policy on its head, but
Mm-hmm.
I'm not a congressman. If they want to make that decision, they can make that decision. But all the evidence that I've seen is that when you let states or force states to implement work requirements in Medicaid, you get barely any increase in employment and dramatic drops in enrollment in Medicaid.
Mm-hmm.
Going the opposite direction of just saying, hey, anyone can get Medicaid, make the requirements looser, probably actually increases employment more, because more than saying you have to prove that you've tried to have a job, tried to do community service, all this, because making people fill out forms to say that they have a job means that they don't have as much time to go do a job. Right. And the worst case scenario situations that I've seen is requiring people to fill out these forms every single month, which can you imagine if your health insurance
every month
required you to fill out a form every month that basically said, yes, I did let me report every job that I have, but every single task that I've done at Red Sail. Right. I recorded this podcast. I did this. It was this many hours a week. Please let me keep my insurance.
I would not have insurance immediately. Probably. I suck at anything like that.
who can fill out a form every single month, let alone people who are the requirement
Robots.
is for a single person. Just the income limitation to Medicaid is $20,000 a year of income if you're a single person. If you're a family of 5, it's $50,000 a year. But if you're actually trying to do work to earn money for your family, you don't have time to fill out all these forms.
No.
And every hour that's spent filling out the forms to prove that you are still working is an hour that you're not able to work or put food on the table for your family. So I think it's a misguided policy. I don't think it's a good idea, but to me, it's mostly just a way to cut Medicaid and say, being poor is bad. Not really a way to actually get people to work more, because if you wanted people to work more, you would give them less paperwork to fill out, not more.
Got it. What about going back into the pharmacy though, just in general? Like I see you in, I'll just say your
I work
advocacy
one
role so
day.
much.
Yeah,
I was gonna, how do you even have time to be in the
right.
four walls?
Yeah,
Yeah.
so,
Okay.
so so I work one day a week at the pharmacy.
Okay.
And
I
then
thought so.
depending on the week, I might go in for a couple hours to help as well, like as needed. Like yesterday was not my day in the pharmacy, but I went in for 3 hours to go help out because one of our techs didn't show up, and so we were short staffed. So I was able to jump in for a little bit. So mostly I'm working on advocacy stuff, consulting work with other pharmacies, helping them understand how third parties work, how generic effective rates work, um, how to use um, the various cool tools that Pioneer gives us to actually earn some money. Um, like you can do a lot with triggers, man.
Yeah. Talk about that. Talk about like what you're helping pharmacies do, or operationalize, I guess. And
Yeah, sure.
that's something I think everyone sees you on LinkedIn, and obviously as a consultant too. But like in your advocacy work, I think sometimes it can get lost about how many pharmacies you actually like
Yeah,
on the phone with helping.
right. I mean, I was on the phone with a pharmacy in Texas yesterday. And what I was helping her with was I think there's a right way to do third party organization in the system.
Okay. Okay.
Um, like specifically for Medicare. Um, I think that pharmacies should have a record for each Medicare Part D and each Medicare Advantage plan in their state and in their county. So like for this pharmacy, there's 60 options for her Medicare customers. Um, and having a separate record for each that's organized against the contract ID and plan benefit package code um, is it's really helpful for understanding like, okay, how did this person's drug benefits get determined? How much are they paying per month in premium? It can be really helpful for helping people select plans as well. Like, oh, hey, Mrs. Jones, it looks like you're on this one plan that, you pay $200 a month for. Did you know there's this other one that has like the same benefits, but it's free? Um, let's talk about that. But also like, um, you can figure out which formulary someone has. And um, so one of the things that I do is like structure third party records and then put notes in that represent what the copays are for each tier of a formulary, what premium is in place, what deductible is in place, and then a link out actually to the plan's formulary so that you can say, oh, I'm trying to bill Spiriva. It's not on formulary. What is on formulary? Oh, Brez Tree Aerosphere is on formulary or whatever.
Mm-hmm.
Um, and so I'm going to tell the doctor based on the patient's plan that they're actually enrolled in and their actual formulary, this is what we should do. Because like it's one thing to say, oh, they're on this group number. It's an entirely different thing to say, oh, they're enrolled in AARP Medicare RX Saver Plus.
Right.
I know the exact plan. I know the exact formulary. The copay is going to be this. So, because like one of the things that I think makes a pharmacist, I think, can be really helpful to patients, especially when they have a concept of like three things. One, we can source a drug. Two, I know what the drug's like going to cost the patient, not only in terms of my own costs, but in terms of their their plan benefits.
Mm-hmm.
And then also like clinically, this is a useful drug.
Right.
That to me, like a pharmacist that has the skills of a grocer to be able to source the drug, skills of an insurance agent to help them understand the costing, and then the clinical skills of a pharmacist and a physician to help them understand the like why this drug is the right choice for you. I think when you can blend those three skills, you have a very powerful combination.
Mm-hmm. Again, like I know I made you spend a lot of your time talking about advocacy and policy. Is there anything else, and some of your consult that you want to make sure we bring up here before?
No, man, I think we've covered
shuffle
it.
out. Okay,
I think we've covered like the stuff. There's obviously a million and one things we could talk about, but I think to me that the most important thing is this concept that, we try and get a bill across the finish line to say PBMs shouldn't own pharmacies.
Yeah, got it. From it's still Apex as far as your consulting links go. We'll put the Apex piece in the you and Joe. I still do all that stuff, so we'll put that in the show notes as well. All right, man. Well, I'll see you in a few weeks, actually.
Okay. See you in 2 weeks or something.
Face, man.
Okay.
All right, man. All right, dude. Tthanks, man.
Thanks,
See
Mark.
ya.
Bye.
All right. Bye.